to the Thyroid Trust presentation for today. As many of us know, and as people join, we'll be talking about hormonal health, and it can be a wide-ranging issue for women, as we know, and when combined with thyroid disease, can pose significant challenges. Dr Farah Ahmed is joining us from Newsweek Health. She is a GP with 15 years experience and a very special interest in women's health and the menopause. And we're delighted to welcome her to one of our Thyroid Trust presentations, which is recorded and then we will be uploading to YouTube and through our website as well. So a regular speaker on women's health, Dr Ahmed is committed to delivering proactive, preventative, personalised care to women at every stage of their life. So as we go through, if you have any questions, please place them in the chat. And towards the end, I will try and put as many of those, group them together, etc., to Dr. Ahmed, and we can really gather some insightful experience today, I think. And as I say, for colleagues and friends who can't join us, this is recorded and put up onto YouTube afterwards. So thank you very much. Over to you, Dr. Ahmed.
And good afternoon. Thank you. As I mentioned, I'm a women's health GP and a menopause specialist as well. And I've recently joined a rather fabulous Newsweek Health group, which specialises in menopause, PMS, PMDD, and all sorts of menstrual disorders as well. Basically, I'm a GP with 15 years of NHS experience. Recently developed an exclusive interest in women's health, and now I work for the Newsweek Health group. And this is everything I'll be discussing today. So the first thing to do is understand what is meant by perimenopause and menopause. These are two terms that are bandied around a lot at the moment. If you're not aware, it's currently Menopause Awareness Month. Okay. Right, so first of all, what is menopause? Well, it's exactly what it says in the tin. So cessation of periods. For the purists, it's a Greek word, meno, coming from the word month, pause, cessation, so no more monthly. But clinically, we define it as 12 months after your final period. So it's a diagnosis of 12 months, then you are deemed menopausal. And there are various types of menopause, believe it or not. Most women experience a natural menopause. So yes, various types of menopause. So I mentioned natural, but induced as well. So for women that have had their ovaries removed, a procedure called an oophorectomy, that automatically, their hormones literally vanish overnight along with their ovaries. And it's important to recognize the difference, because for women that have had a surgical menopause, the symptoms are often more abrupt overnight, and these women often need higher doses of HRT compared to women that go through the menopause naturally. And then the average age of menopause in the UK for white Caucasian women is about 51. However, for women like myself, Asian women or women from the Black community, it's actually a little bit earlier, around about the age of 46 or 47. But the range is typically from the age of about 45 to 55. At some point, the majority of women and then we have the past between 5 and 8 years, and that's usually a consequence of your hormones kind of dancing to their own rhythm. You don't have that nice cyclical, predictable rhythm to it. And because we have estrogen and progesterone receptors literally from our head to our toes, that symptoms can manifest with pretty much anything. So perimenopause, but there's often things like brain fog, low libido, dry skin, dry eyes, joint aches and pains, vaginal dryness, you name it, lots and lots of symptoms that are all part of the perimenopause. And like I said, that can last for a whole 5 to 8 years ahead of the menopause. And then important to note early menopause as well, and that usually affects women from the age 45. And again, we need to have more of a chat about the role of HRT for these women. And then we have another subgroup, which is defined as premature ovarian insufficiency. A little although we tend to see it quite commonly in our menopause clinics, and that's women that reach menopause under the age of 40. And it's quite relatively common, actually. It affects up to 1 in 30 women, we think. Right, so why does menopause happen? Well, a female baby at birth is born 1,000,000 eggs, but by the time she hits puberty, she's already lost about 20% of her eggs. That declines down to a third, so about 300,000 by the time she gets to 25. And then from the age of 35 onwards, pretty much when the perimenopause kicks in as well, there seems to be a much steeper decline of ovarian reserve. Menopause, there are no viable eggs left, and natural aging of the ovaries age faster than we do. And menopause doesn't only affect it doesn't only present in terms of symptoms, but it also impacts long-term health as well. And although it's a natural part of aging, it can take up to 30% of a woman's life, because that's how long is spent in postmenopause. And that wasn't a problem 150 years ago in the Victorian era, where a woman's life expectancy was around about 55. So she'd only spend about 3 or 4 years in postmenopause. However, now that if you assume a woman hits menopause at about 50, and the average life expectancy of a woman in the UK now is 83, she will spend up to 3 decades of her life postmenopausally, and that's a huge chunk. And a fun fact for you, we think there are 13 million women in the UK who currently postmenopausal, which is a huge number. About a third of all women in the UK are postmenopausal. And the reason that's important as well, because data tells us that although women are living longer, they have a longer lifespan, but a shorter health span. So they're spending more of that time in poor health. And there's lots that we can do to help them increase their health span as well. You should mention there's numerous health risks as a consequence of your heart health, your bone health. Various data suggest it can affect your brain health as well. So it affects things like memory and cognition, concentration, all sorts of things. And for women over the age of 45, it's often a clinical diagnosis. We don't really need blood tests in this subset if the history is quite clear from women's symptoms. So it is very much about treating the woman and not the numbers. And so how big a problem is menopause? Well, globally, 47 million women reach the menopause every year. So that's the size of England every single year. And in this country, about 80% of women have visited their GP about their symptoms, but staggeringly, only 7% of them have had the GP more than 10 times before receiving adequate help or advice. Every woman is different. We think there are about 90 symptoms that can be attributed to the menopause, so it's not always clear, which is why it's really important to ask for a specialist in women's health or someone that's done some additional menopause training. And almost half of them who eventually do receive treatment have had to wait over a year or more, with 12% waiting 5 years, which is a bit of a disaster, isn't it? So I quite like sharing this graph with my patients, because it's a good representation of what's going on during the menopause transition. So it's women often think they're going mad, their partners, their children all think they're going mad, but they're not going mad, it's their hormones. So if we look at the middle section, the reproductive years, we can see that there's quite predictable fluctuations in the hormone estrogen. That's the dark green line, very up and down cyclical. Progesterone, again, smaller waves, but fluctuates as well. And if we move to the right during perimenopause, we can see that there is a gradual decline and the fluctuation isn't as predictable as it once was. And that's when you tend to experience all your perimenopausal symptoms. So those hormones deteriorate quite steeply to a very low basal level. And the aqua colored line, that's your testosterone, which kind of peaks in your teens. And then it tends to be a more gradual decline. So These are 3 pictograms that can be found on the Balance app and the Balance website. So these 3 images can be found on the Balance website or the Balance app, and it's a great resource, not just for tracking your symptoms, also creates a health report as well that you can take along to your GP appointment or your menopause specialist, but also, more importantly, for you to learn about the roles of these hormones and also to recognize if you're experiencing any of them. So we often talk about physical symptoms, but mental health is huge as well during this transition. And I kind of feel like women who are perimenopausal and menopausal are often the sandwich generation, where we're kind of squeezed between aging elderly parents who we sometimes have to look after, but also we often have children as well who are dependent on us. And so, as usual, our needs come last. And so we can't be, a huge part of it could be a result of your hormones. And one thing we don't pay enough attention to is the effect on our mental health. So we know estrogen has lots and lots of roles, but also has a fantastic anti-inflammatory role, which helps improve blood flow to the brain. This can help reduce anxiety, improve sleep, helps with concentration, memory, energy, mood, all sorts of things. And women are so often prescribed antidepressant for their mood symptoms when actually it's probably all part of the perimenopause. And similarly with progesterone, that can also have huge consequences in terms of improving your mood, sleep, brain health, and memory as well. And testosterone, again, all very good for brain health. So common symptoms of perimenopause and menopause. Well, as I said, the ones that people most associate with menopause is hot flushes and night sweats. And the problem is if they have an absence of these symptoms, which a lot of women do, they kind of think, well, it can't be perimenopause or menopause because I'm not experiencing the hot flushes and night sweats, which everyone seems to be talking about. But as I mentioned, psychological symptoms are very, very common, but also can throw up some surprising symptoms too. And symptoms that users of the Balance app have reported as most commonly are the brain fog. So if you walk into a room and you have no idea why you walked into it, if you open the fridge and find you've put your car keys there, if you pick up your phone to message someone, you have no idea who you're messaging, things like that are very, very common. New onset anxiety as well, where suddenly you're just feeling a bit more jittery, a bit more anxious when previously that the same things didn't trigger you as much. Forgetfulness is also a big one. Low libido is huge as well, and it's something that women don't often volunteer, so it's really important for GPs to proactively ask. It's something I proactively ask about sexual health and also libido as well, because that can have a ripple effect in terms of into your relationships. Headaches, bloating, irritability, and as I said, trouble concentrating, mood swings, feeling tense, all sorts of things. And we think there are about 96 symptoms that can be attributed to perimenopause and menopause. There are also physical symptoms as well. So things like poor sleep, fatigue, change in periods, it's quite common. And again, on the Balance app, we have a really good bit of tracking of period and things like that. So it's really important to use apps and things. It's very helpful to us as clinicians to measure those things. Joint pains and muscle pains, which women often put to, oh, well, I'm over 40 now, of course I'm going to have these things. But no, again, it could be the hormone. And similarly, hair thinning, dry skin is very common, as well as headaches. Weight changes is another big one as well, where you may not be gaining weight or losing weight, but there could be a change in the shape of your body as well, because you tend to gain a lot more weight around the center of the abdomen. And then things like dry eyes, dry mouth, dizziness, and urinary vaginal symptoms, very important. And again, something that women don't really volunteer or pay much attention to, because I guess there's so much else going on. But that's a huge one, where you just find that you're suddenly waking up at night to pass urine a few times a night, or you can't hold on to urine as well as you used to. You go to the GP, you get treated with multiple antibiotics, you keep getting told you don't have a UTI, incredibly frustrating, but it's often due to something called GSM, genital urinary syndrome of the menopause, vaginal dryness, and it's very, very easy to treat with some localized estrogen. And that's something I would definitely raise with your GP. Okay. And then psychological symptoms I spoke about as well. So new onset anxiety, which is quite common in this age group, which goes hand in hand with panic attacks. Irritability as well, especially with those around you, often partners, siblings, best friends can experience that. Just feeling low without really knowing why, and the constant mood swings as well, just feeling frustrated, tearful, low self-esteem. So much overlap between anxiety, depression, and psychological symptoms of menopause. It's often difficult to tell it apart, to be honest, but we just take that, we kind of have a holistic view of what's going on in your life, how old are you, tell us about your menstrual history, any other symptoms, and try and build a picture of what's going on. And apart from the symptoms, yes, there are long-term consequences as well. So menopause can increase your risk of cardiovascular disease as well. It can also increase your risk of osteoporosis, which is bone thinning. As I mentioned, vaginal and urinary issues, as well as reduced brain function. So in terms of bone density loss, as women get older, their bones will become thinner and weaker, which can initially lead to osteopenia, and then that can progress onto osteoporosis, which is essentially brittle bone disease. We think without any intervention, without any lifestyle changes, no calcium, vitamin D optimization or HRT, up to 50% of women by the time they're 80 may develop osteoporosis, and that can massively increase your fracture risk. And the reason that's really important is because if women that sustain fractures in that age group, the fractures can prove fatal. And so it's something that we can do a lot about to mitigate our risk now. It doesn't always involve HRT, but HRT is a good option, but also things like weight-bearing exercise, resistance training, and as I said, optimizing your calcium and vitamin D all really, really help to strengthen those bones. And that's something I emphasize so much to a lot of the women that come into my clinic, that if you don't have time to do your cardio, that's fine, because you'll get your cardio through the normal walking that you're doing, but please start lifting heavy things. And if that's one takeaway that you could all take from this, that's the one thing I would say, just start lifting heavy things. Also, it increases as you enter menopause, your risk of type 2 diabetes increases as well. And that's not as a direct consequence of menopause, but this is a consequence of aging as well. Obesity, it just becomes a lot harder to lose weight. And as I said before, we tend to develop this central obesity where a lot of the fat seems to be deposited around the abdominal area, whereas before it may have been the thighs or breasts or elsewhere. Risk of heart disease goes up as well. And also mood issues, depression, psychosis, in some rare situations that can lead to suicide. So I feel like I'm probably preaching to the choir here, but again, just to ensure we're all on the same page, the thyroid is a vital hormone gland. It's located just at the base of the neck in front of the windpipe, and it's a butterfly-shaped gland that's part of the endocrine system, so the hormonal system. Two main functions are to control your metabolism and also to control growth in early life. And it's involved in lots of body functions that are control metabolism, something called homeostasis, so ensuring our hormones are working, ensuring the menstrual cycle is regulated as well. And there are several different types of hormone produced by the thyroid gland, which include your T3s and your T4s. So having an overactive thyroid is called hyperthyroidism, where the thyroid gland is working a bit too hard and producing the thyroid hormones in a quantity above normal. Conditions like Graves' disease can cause it, and it can also grow in response to poor function. And symptoms associated with an overactive thyroid include weight loss when you're not trying to, feeling hot all the time, even though everyone else is feeling quite, well, normal temperature, ability to regulate temperature, and difficulties sleeping are all part of having an overactive thyroid. And then underactive thyroid, and this is where the symptoms with perimenopause and menopause overlap quite a bit. So this is where the thyroid gland isn't making enough thyroid hormones, and it's mostly caused by the immune system attacking the thyroid gland. Hashimoto's disease is one of the most common types of menopause and hypothyroidism, where two symptoms overlap. So that's the tiredness, the feeling cold, although with menopause it tends to be more hot flushes actually. Weight gain is another combined symptom, poor concentration, constipation, and low mood as well, as menstrual irregularity. That's another important one. And so when the menopause and thyroid issues collide, it's common for women to have one or the other, or indeed both. And it's important to recognize both. So when I see women with perimenopause and they're under 45, I do like to add on TFT, a thyroid function test, just to make sure that it's not their thyroid that's contributing to the symptom. And similarly, in women who are over 45, it's a good idea just to check for that, because that's often when thyroid issues can manifest as well. We know that changing estrogen levels can affect your thyroid function, so it's important to have regular reviews just to ensure you're on the correct doses. And uncontrolled hyperthyroidism can increase your perimenopausal symptoms and make those a lot worse as well, and exacerbate them. So how to diagnose menopause? So as I mentioned earlier, there's no need for blood tests if you're over 45. So we often just go on symptoms. But in women that do have thyroid dysfunction, I do check, if they haven't had a recent blood test, do check for their thyroid function just to ensure that's in therapeutic range. And then all other symptoms we can attribute to the menopause. However, for women who are under 45, it is a good idea to check their hormone levels. It's something called follicle stimulating hormone, FSH, that we like to check. We normally do 2 levels, 6 weeks apart. And the reason is because levels fluctuate, and we just want to ensure that there is some consistency in the blood test, and we just haven't caught one at a peak and one at a trough, for example. And again, like I said, the Balance app is great to help you track your symptoms, and you can produce a health report which you can then bring along to your GP appointment, and it's quite useful for them to have a look at that, because I know sometimes you only have 10 minutes and it's difficult to explain everything you're going through in such a finite amount of time. So managing it is a multi-pronged approach. So we talk about managing risk factors, so cardiovascular health, cognitive health, osteoporosis, especially if there's a family history, meaning that you're probably more susceptible to those things. Also really important to talk about cancer risk as well in this age group. As you age, especially as you're once you become over 50, your risk of cancers increase anyway, simply because of age. So I always like to emphasize that please make sure you're up to date with your smears, you're engaging in your breast screening program, as well as the bowel screening program as well. And then, of course, there is HRT, but there's also non-hormonal, non-medicinal alternatives as well. And also, it's really important to get our male allies on board as well. Women that are perimenopausal, menopausal, are often at the peak of their careers and just have lots of hats that they're wearing. And it's really important to ensure you've got all the men in your life on board to help you help lighten the load, really, and lift some of that burden. So general management, regular physical activity is really important. And as I mentioned, yes, if you grew up like me in the 90s, it's all about cardio, wasn't it? But well, what we know now is weight bearing exercise or resistance training is so important. Doesn't mean you're going to wake up with big bulky muscles, but it just means that as you get older, you're naturally going to lose both bone mass and muscle mass. So it's really important we slow that down or reverse it altogether. And one way of doing that is by lifting heavy things. Don't need to invest in expensive gym memberships or equipment. You can get resistance bands from Amazon for about £10, or just lift heavy things around the house, and that will really help. Lots of great programs on YouTube as well from various fitness influencers that just do body weighted exercises that you can do at home with no equipment whatsoever. Diet is again super important, so follow a gut-friendly diet. So another buzzword at the moment is all about the gut microbiome, so ensuring we've got lots of good bacteria in our gut, because that can lead to all sorts of diseases and inflammation. One thing I often say to my patients is just please try and avoid anything that comes out of a packet other than frozen vegetables being the exception. They're allowed, but things like biscuits, chocolates, sweets, crisps, all the things that I'm guilty of eating. But if you could try and minimize that and try and focus on lots of fresh fruit and vegetables, lots of beans, pulses, nuts, seeds, herbs, etc., and just make that the bulk of your diet. And in 10 years' time, your body will thank you for it. Optimize calcium and vitamin D as well. We live in the northern hemisphere, so sunlight is always a bit of an issue, especially during the winter months. So ensure you're taking a regular vitamin D supplement. And if you are experiencing more joint aches and pains than you'd expect, it might be worth, especially if you have pigmented skin, it's worth getting a vitamin D level checked to ensure you don't need higher doses of it. I think that minimizing caffeine, that can impact sleep, palpitation, hot flushes as well. So to try and switch over to herbal alternatives like green tea, for instance. And as I said, engage in regular screening checks, so your breast, cervical and bowel cancer screening. Just be breast aware as well. As Breast Cancer Awareness Month at the moment, lots of literature on social media about how to examine your breast. And I would say to women, just do that at least once a month if you can. You need to know what's normal, so therefore you can pick up what's abnormal for you. And if there's any bleeding, I mentioned that menopause is where you've not had a period for any bleeding for 12 months after your last period. If you do develop any bleeding after 12 months, it is never normal, and you do need to see your GP or menopause specialist promptly. And don't forget contraception as well. Just because you're perimenopausal doesn't mean that there's no possibility of you getting becoming pregnant. Have seen actually, a few surprise pregnancies in my line of work. So contraception is really important. So if you're under 50, even though you're on HRT, you will need to use contraception for 24 months, so for 2 years. And if you're over 50, you will need to use contraception for 12 months. So let's talk about HRT. So who takes HRT? Well, not as many people as we'd like, actually. So 3/4 of women say they don't know enough about HRT to make enough of an informed choice. And this is something I see time and time again in my clinics. Hopefully by the end of this talk, you'll know a little bit more than the average person. Fingers crossed if I've done my job correctly. In the year 2000, about just 25 years ago, 1/4 of women took HRT, but then there was a study called the Women's Health Initiative, which linked breast cancer to use of HRT. And that created a lot of scaremongering, and lots of women came off HRT, and a lot of doctors were held back on prescribing HRT due to concerns about breast cancer risk. I'm pleased to say that has now been widely debunked, much like the MMR and autism link, which has also been debunked. Lots of studies have been conducted subsequently to show that HRT is actually very safe. But unfortunately, mud sticks, and even now, only about 14% of women who are eligible to take HRT take it in this country. We're doing slightly better than some of our European neighbours, but still nowhere near enough women are benefiting from this. And a good resources are the NICE guidelines, the International Menopause Society guidelines, and the ESHA guidelines as well, in terms of looking at menopause and what to expect at your doctor's appointment. Also talks a little bit about risk as well. But these are really good resources that doctors often refer to when we're considering managing menopause. So let's talk about HRT and breast cancer risk. Well, if we had 1,000 women and we follow them over 5 years and they weren't on any hormones at all, over that 5-year point, 23 of them, 23 in 1,000, would be diagnosed with breast cancer. Now, if we add in women taking HRT, that number would jump up from 23 to 27. So only 4 additional women in 1,000 would be diagnosed with breast cancer. And this is an infographic I quite like sharing with women that are considering HRT, just to contextualize what the risk is from the data that we have. What I don't have in this image is that number, so 23 women without HRT develop breast cancer, and the number jumps to 47 in women who are obese. Yet no one is talking to women who are obese about their cancer risk, and they really should, because their risk of breast cancer doubles. So I just want to contextualize that actually being obese, smoking, not exercising, increases your breast cancer risk quite massively relative to HRT. So can you take HRT with a thyroid issue? Well, yes, you can. And the safest way of taking HRT is through the skin. It comes in pretty much every form imaginable. You can take it as a tablet, as a gel, as a spray, as pessaries, as patches. You can get rings of HRT as well. But the safest way for people with hypothyroidism is to take estrogen to the skin. So that would be either through a patch, a gel, or a spray. And the reason is it goes straight into the bloodstream, bypasses the liver, doesn't interact with any other oral medication that you're taking, and we know that it helps combat symptoms best, but most importantly also it helps reduce your clot risk as well. So that is our preferred option of offering HRT to women. HRT may affect the dose of your thyroid medication. We know that that tends to be more estrogen linked, not so much progesterone or testosterone. So it's really important to have regular reviews with your doctor, to have regular thyroid function tests, just to ensure that your hormone levels are within the recommended parameters. HRT can also sometimes improve thyroid function as well. And as I mentioned, it's really important to have regular checkups and follow-ups and blood tests. Will I put on weight? So this is another big one, and a natural concern for people, especially with hypothyroidism, with an underactive thyroid, because we know weight control can be really, really frustrating. So almost 70% of women say they gain weight since perimenopause, and they tend to gain it, as I mentioned, more abdominally. So and some women may not gain weight, but the shape of their body just changes. And they can often gain weight when there's been no change to the lifestyle, but unfortunately metabolism changes and the body is desperate for estrogen. And because the ovaries are no longer able to produce estrogen, it can sometimes extract estrogen from fat cells. It kind of lays down fat cells in the abdomen to try and get to estrogen that way. So it's just the body trying really hard just to keep you in your premenopausal state. And other reasons could be changes in your thyroid function or your medication that probably needs adjusting or tweaking. Again, I mentioned the hormonal fluctuations as well. Also, women may be inclined to exercise less with perimenopausal symptoms if they're feeling down, depressed, hopeless, lacking energy, fatigue, not sleeping. The last thing you're going to want to do is go out to, for a 2K run or start lifting heavy things, and also all the psychological symptoms as well. There may be with food issues, again, due to psychological symptoms, where because you're feeling a bit rubbish in yourself, you're less likely to make healthy food choices and comfort eat and things like that. And as I mentioned, sleep disturbance for a whole host of reasons. So that could be because of urinary symptoms, you're suddenly waking up 2-3 times a night, which is disturbing your sleep. Night sweats are disturbing your sleep. Hot flushes are disturbing your sleep. And if you have disturbed sleep, that has such a knock-on effect on all sorts of things, not just your mental well-being, but you're more tired, more fatigued, and less likely to engage in a healthy lifestyle. So will HRT make me gain or lose weight? So it's not prescribed for weight loss, and there's no evidence that it will make you gain weight. But what it does do is help manage your menopausal symptoms. And so if you are feeling better about yourself, the theory is you're more likely to engage in healthier lifestyle choices. And then alternatives to HRT, or that GPs can prescribe things like antidepressants. There's nerve medication as well, gabapentin, pregabalin. Some of those can make you gain weight, and also things like clonidine and oxybutynin. I tend to reserve those for patients who can't take HRT for a good reason. For example, if they've had blood clots in the past, history of breast cancer. These medications only really seem to work for hot flushes and night sweats, and less so for other symptoms. But obviously the antidepressants can also help with some psychological symptoms as well. And other alternatives, which are non-medicinal, is CBT, cognitive behavioral therapy, which I think can be such a game changer, and it's something that isn't really talked about much or given as much credit as it really deserves. But that can really be so helpful in helping to manage women's mood symptoms. And the theory is that if you feel better in terms of your mood, in terms of your cognition, and how you feel about yourself, you're better equipped to deal with the perimenopausal symptoms, and it can also help with anxiety as well. So it's very much a holistic 3D approach to managing menopause. And then there are alternatives on this some about and with my patients about the role of things you've probably heard of, red clover, St. John's wort, black cohosh. And yes, although they're herbal products, it doesn't necessarily mean that they're safe. We know, for instance, St. John's wort can interact with a whole host of other medications that you may be on. They can also affect the way other drugs are metabolized that you may be taking, prescribed medication that you're taking. So it's really important that I wouldn't take these things lightly just because they're herbal or natural, because they can interfere with other drugs. I would just say just speak to your GP, but it's often difficult. I will say this now, it's difficult as a GP to recommend these things just because they don't undergo the same vigorous research and studies as prescription medications do. And in terms of resources, so here are two QR codes. One is linked on the left to the Balance app, and that's that I mentioned during course of this talk. It's a really good resource, literally in your pocket, to learn more about hormones. You can also log your symptoms, and also develops a health report that you can take to your GP clinic. And the QR code on the right is a link to our Newsweek clinic. So we offer menopause appointments, as well as PMS, PMDD, and lots of other hormonal disorders as well. I've got two clinics, one based in Stratford upon Avon and another one in London, but we offer virtual appointments as well. And each appointment is 45 minutes long, so it's not rushed. And we also have Louise's book, Hormones Unlocked, and her other book as well, Definitive Guide to Perimenopause and Menopause, and QR codes are there if you'd like to consider purchasing them. Great resource. And that's it. I'm happy to take questions and really appreciate some feedback as well.
That's lovely. Thank you so much, Farah. If you could stop sharing your screen and put your camera back on, and then I have got some questions that have come through in the chat, and I can do the same, and we can represent. That's it, lovely. So I'll take them in the order they came, so it'll take us on a leap back first of all.
Yeah.
May was asking, is there an impact on women at the point when testosterone drops quite significantly midway through the reproductive years?
Well, you may not notice the impact of testosterone dropping until you reach perimenopause or menopause, because it seems to be more of a gradual decline and then slightly steeper when you enter your perimenopause. And the way that often manifests is with reduced libido, reduced muscle mass, you don't feel as strong. And so we tend to go for estrogen first, estrogen with progesterone. And if you're on a good dose, but that's not controlling your symptoms, especially when it comes to libido, then we can consider adding in testosterone as well. And we do that guided by blood tests, because it's really important to ensure that testosterone levels are within a physiological range. Otherwise, you will develop symptoms like excess hair where you don't want it. It can affect your voice, enlarge your clitoris as well, and you can get even hair growth, low hair growth where you apply it sometimes. So it's something we need to watch quite carefully.
Thank you. And so this is probably a ubiquitous question for thyroid patients particularly, but and I'm very lucky not to be in this situation, but what happens if your GP surgery is unhelpful?
Yes, I get that a lot because I work in an NHS menopause clinic. So I guess the women in our patch are quite lucky because they get referred to us. A couple of things. So I would ask if you can book a double appointment, because you're not really going to achieve much in 10 minutes. It's so rushed. So do ask if you can book a double appointment. Secondly, ask if there is a women's health specialist in your surgery. There often is actually a female doctor, or even a male doctor that's done additional qualifications or diplomas in women's health. Even if you have to wait longer, it's probably worth it because you're more likely to get something to that appointment. And thirdly, if that's help, ask either for a second opinion or if you can going menopausal care.
Okay, that's really helpful. And this is the other one, which is thyroid or menopause, and you touched on this, and that is something that I can identify with, and not
Mm.
having a lifetime of a thyroid issue, just not recognizing when it was actually not that, and it was the menopause, um, and similar symptoms. So how can you navigate? Wonderful phrase. How can you navigate that course? Claire asks.
Mm. So with thyroid, it can depend on age. So for example, if you're 32 and you're feeling fatigued and brain fog and weight gain and things like that, I'm probably more inclined to think that this is a thyroid dysfunction rather than, well, what would be very early menopause or premature ovarian insufficiency. But in both, for a young woman, I would check hormonal levels, not just thyroid levels, but hormonal levels that could suggest early menopause. But in a woman who is, say, in her 40s, and like I said, there's such an overlap. So where the diagnosis is at, I always tend to, as standard practice, add on a TFT test, just to ensure that I've ticked that box and there's no thyroid issue to contend with, and then we could just focus on menopause. And if the thyroid comes back within normal range and they're over 45, then we just treat them for perimenopause, because that's almost certainly what it is.
So in terms of the GP surgery or the GP not recognizing it, rather than immediately saying, well, I'll have to change GPs if that's possible,
Mm.
is to sort of have those key questions to ask. Could I have this blood test? Could you check this, please? Or could it be, etc.?
Most sensible GPs should check thyroid
Mm.
function checks. Also, things like anemia, iron deficiency, if you've got bone aches and pains, vitamin D. And after 40, you should have at least a bit of an MOT,
There's
where we're at, because a lot of changes take place in the 40s. So often, you should hopefully be things.
and similarly to this, where you were just taking that and it did break up a bit, but Claire was asking about sources of calcium and vitamin D which don't have high iodine content, because again, that's something in terms of balancing the vitamins. And
Mm.
Laura says she's taking 3,000 grams of vitamin D, not grams, grams,
Mm.
and it is helping, but is that a high dose?
Yeah, so the maintenance dose is between 1 and 2,000. And the problem with taking high doses with without medical supervision is, in theory, you could develop vitamin D toxicity. So if you are going to take, well, I would advise not taking higher doses, but if you are concerned about vitamin D deficiency, I would say just get your levels checked with your GP, which should be very straightforward, and then they will be able to tell you how much vitamin D you need, because it is calibrated according to your level. There are different parameters, and if it's between 20 and 25, for instance, it's a certain dose. If it's below 25, it's a much higher dose. So we do calibrate the dose according to your level, but a maintenance dose, I'd say 1 to 2,000. And if you belong to an ethnic minority, I would probably err on the side of caution and go for a 2,000 dose, especially during the winter months.
That's excellent, thank you. And is the impact of HRT on hyperthyroidism similar, or as significant as hypothyroidism, or is it hypothyroidism, or is how does that work?
Well, again, it can be a bit of an overlap. So there's a night sweats, and then people are hyper. It's tricky for us to tell from the history which one it is. And again, that's where blood tests and also a more of a background as well. Tell me about your menstrual cycles, tell me about your lifestyle, tell me about your family history, because if early menopause or thyroid runs in the family, that could help give us clues. So it's not a quick answer, to be honest, Valerie. It very much goes
I
on
know.
delving deeper and asking lots and lots of questions, and the role of blood tests as well to help differentiate.
And on the blood tests, this is quite a usual one for thyroid patients when they have theirs. But presumably sometimes you're going to be sent for a combination of blood tests, the thyroid scan and other scans in terms of the menopause. Is there a best time to go to get that the most accurate reading for what the doctor needs to see?
Yeah, I mean, my endocrinology colleagues might say it's better in the morning, but the problem is, in reality, you will just take an appointment when you're offered one. You're not always offered a morning appointment. So I just say that just have an appointment whenever you're offered it, because if there is something glaringly obvious, it will show up in the blood test, and then we can just, repeat it if needed. But let's just do a baseline quickly just to see where we are. But things like cortisol do fluctuate, but thyroid less so.
Mm. So that's is so one of the things I was wondering, is there any promising new research or therapies emerging in hormonal and thyroid health that you're seeing on the horizon? I'm not asking you to promote them in advance,
Yeah.
but
To be honest, not that I've heard of. My endocrinology colleagues may say something differently, but as someone that sees a lot of thyroid patients within primary care, it is still very much your things like your carbimazoles and your levothyroxines. But I have seen my endocrinology colleagues use more advanced things, but that's not something that's filtered down to primary care just yet.
right. Well, that's good. And so for women listening who are just feeling a bit off, they may have a thyroid condition, they may know they're going through the perimenopause or the menopause, whatever situation they're in, how would you suggest they both best approach it?
Mhm. So I would say log your symptoms. That's really, really important, because sometimes you get into the GP clinic, you're already flustered, you've got 10 minutes and you feel rubbish anyway. So I would say log your symptoms so it's there. And I literally have patients sometimes that just hand me the phone and say it's all, and that's fine, because I just need to know the information. So if you find that, you are that, that way inclined, just write it down. And for at least 3 months is really, really helpful. Your menstrual history is really important. So I want to know your last 3 cycles, how far apart they were. Tell me about the blood flow. Are you passing any clots? Any other symptoms as well? Has your partner, your children, they mentioned things about, mum, you're always so irritable. Tell me about your sleep pattern. Tell me about what you're eating, your lifestyle, all sorts of things. And like I said, it is a lot to try and squeeze into 10 minutes, but just writing it down would just help streamline and create a bit more of a smooth experience for both you, most importantly you, but also the doctor as well, in terms of focusing.
And I think that thing of remembering, if you are a thyroid patient, saying, could this be the menopause? And if you're not, is, could this be my thyroid? It's that
Mm.
it's just keeping those things open as well.
Yeah, and the same for us as clinicians as well, where often it can be one or the other, or it could be both.
Mm. And finally, it's been really interesting, and that bringing those two things together is very difficult. But is there a hopeful or empowering message you'd like to leave people with today, or about taking control of their own health and their own well-being,
Yeah.
and overcoming some of the challenges?
Yeah, I would say we're very lucky where we live in a social media age, in almost information overload, and there's lots of great resources out there. Dr. Louise Newson, you can follow me on Instagram, and I would say just be very careful where you get your advice from, though, and just make sure it's from trusted sources. So I've mentioned the NICE guidance, the International Menopause Society guidance. If you are going to follow people on TikTok or Instagram, whatever, just make sure they have the credentials so you're following bona fide doctors as well. But also other websites as well. There's Rock My Menopause, Menopause Matters, as well as the Balance app as well, where lots of FAQs, and it comes with great pictograms as well. So in terms of just arming yourself with knowledge, and just think, does this sound like me? And if it does, just book in for that GP appointment, and even say to them, I'm worried. This is what I got. I'm not sure whether it's my thyroid or my menopause, and I really would like some help in managing this.
That's great. And also, just one more question that came up, which is about where women are on the pill, or maybe
Mm.
they've had laser ablation surgery, and so therefore are not having periods at the time they go through their menopause. So they don't really know. It's keeping an eye out for those other symptoms. Is that
Yes.
right?
Yeah, and we have lots of women like this, like you mentioned, endometrial ablation, women that have the coil as well, the Mirena coil. they haven't had a period, so they're not sure where they are. But it's more everything else, all the other symptoms. And the contraceptive isn't going to mitigate against those symptoms. They'll still manifest in some way or another. So if you are experiencing those, but you're not able to give us a menstrual history, that's fine, because we can still go off your other symptoms.
And I think that that's certainly something but you're right about the reliable information. And one of the things, well, I've taken a lot away from this today, but is that as the Thyroid Trust, one of the things we will look into is looking at that question about the diet for the multivitamins and the vitamin D particularly that don't then include a high level of iodine like eggs, etc. So we will
Yeah.
look at that and that support, and we have other things. So thank you very much, Dr. Farah. That's been,
You're welcome. Sorry about all the tech issues, but we've
I
got.
think we all sort of got through that. I will try to edit them out and make it smooth for the recording,
Mhm.
but it essentially the message came through is about how to keep it clear, keep your mind open as to what it could be, and take control of your health as best you can, because we all deserve to have the best experience that we can and not
Absolutely.
to experience those side effects of the menopause and of thyroid disease. So thank you very much.
Great. Thank you so much.
Thank you.
Bye.
Bye bye.